All right. Hi, everyone. My name is Angela, and thank you for joining the Pulmonary Hypertension Association's live webinar, Respiratory Infections and Pulmonary Hypertension, presented by Doctors Nidhy Varghese and Dr. Ivan Robbins. Before I do get started with their full introductions and bio, we do have a couple of programming notes. First, we would like to thank Janssen Pharmaceuticals, Inc. and Merck and Co. for their diamond level support of our PHA Connects, as well as United Therapeutics Co. and Bayer Co. for their gold level support of PHA Connects. So thank you to our sponsors. We would also like to make note that as a nonprofit organization, PHA relies on the support of its members to fulfill its mission to join our global and to fulfill its mission. I'm so sorry. So join our global support and our global network and enjoy access to future programming, PHA events, webinars, and publications. If you are a member, thank you so much for your support. If you are not currently a member, please consider joining our membership for PHA. So again, our programming notes, we will have Q&A immediately following our presentation and discussion from our panelists. Please, as a reminder, to use the Q&A button and feature on your toolbar. You'll see it at the bottom of your screen to submit your questions to the panel. And a reminder with your questions, please keep them general. If you do have specific care questions, we suggest that you submit those to your personal healthcare team. And lastly, we will have a post-webinar survey to pop up at the conclusion of our webinar. It may open in a new window. This survey is to help us create future content and present future lives for your educational needs. So we thank you for joining us, and we hope that you will stay tuned to the end for the question and answer portion. And now about our speakers. We have Dr. Robbins, who is someone we are very lucky to have. He is the Director of Adult Pulmonary Vascular Center at the Vanderbilt University. And we have Dr. Nidhy Varghese, who is the Medical Director of Texas Children's Pulmonary Hypertension Center and an Associate Professor of Pediatrics and Pulmonology at Baylor College of Medicine. Dr. Varghese and Dr. Robbins will lead this discussion on adult and pediatric information on respiratory infections. And so I will now turn it over to Dr. Varghese.
Thank you so much, Angela. Thank you so much for that wonderful introduction. And thank you to the PHA for this opportunity to speak on respiratory infections in children. I'm a pediatrician, in children and in adults, which my colleague, Dr. Robbins, will speak about. Dr. Robbins and I, we really wanted to just highlight a couple of key information points about infections, specifically as it pertains to pulmonary hypertension patient populations. But we wanted to maintain a good amount of, or reserve a good amount of today's session to have conversation from all of you. What are your questions? What do you want to know? We want to be here to answer those that may be general questions that everybody can benefit from learning the answers to. So a little bit about respiratory infections. It seems that these days, every time you open the newspaper or listen to the news, you're hearing about new waves of infections. It's been a particularly rough year for pediatrics when it comes to infections because of high rates of infections like RSV, which is respiratory syncytial virus, and rhinovirus, parainfluenza, and then influenza, which is also known as the flu. These are a number of viruses that have been really, really active this year. And most of those viruses are ones that you all know the words of. You've heard those words before. Human metapneumovirus is another one, which is a little bit less well known, but that one is another virus that also causes respiratory viral illness. So this year has been kind of tough, and it's been tough for a number of reasons. One of which is that it seems since COVID, since much of the Northern Hemisphere, much of this country specifically, went into quote unquote lockdown and our social practices changed, many of us for 2020 and part of 2021 just didn't get sick. And we didn't get sick because we weren't in areas with a lot of commingling. People were masking still, and people were everywhere very concerned about getting sick. So hand washing was ubiquitous, hand sanitizers were everywhere. And we didn't get sick during that time. And unfortunately, a lot of us suffered a drop in our immunity. And so as this immunity level changed, when this year in 2022, when everybody kind of went back to school, back to work, we were all confronted with viruses that had been kind of lingering around, and we suddenly were not immune to them as we were in the past. So many people this year, not just children, but adults also, were getting sick. Most of these, I think, were coming home from kids from school. Kids are bringing things home from them, with them from their school days. And of course, the caregivers and families were getting sick with that. So what some of the big ones to highlight are RSV, and the other big one is flu. So RSV and flu had particularly rough seasons this year. So first, a little bit about RSV. So RSV is known as respiratory syncytial virus. And this virus, unfortunately, does not give lasting immunity. So you get sick with this and you can continue to get sick with it again, although in the same season, it may be less serious. Oh, and a virus I forgot to mention was rhinovirus, which is also known as a common cold. And so rhinovirus was another very, very active virus this past season. So RSV is particularly worrisome when it comes to young infants, because some infants, babies, when they get sick with RSV, they can actually stop breathing. And that's a condition known as apnea. And it can be pretty scary. And sometimes RSV can actually be life-threatening. When you specifically have a child with pulmonary hypertension, a baby with pulmonary hypertension, or even a young child with pulmonary hypertension, RSV can be a very dangerous infection and sometimes can result in hospitalization or in serious respiratory support needs like ventilators, or even life support measures like ECMO. And unfortunately, RSV has had a lot of seasonal change this past year with changes with COVID, we think, and also just seasonal variation of the way the viruses themselves were spreading. So RSV, which is typically more in the winter months or kind of those cold viral months, we were seeing it over the summer as well. So RSV is an infection which can cause a lot of problems, specifically for infants. And so we have a medication called Synagis. Synagis is a monthly injection that's given to children who are at high risk of having a bad outcome from RSV. And babies who have pulmonary hypertension, they qualify for Synagis. Synagis is given once a month, typically for 5 to 6 doses total, so about 5 to 6 months worth. And it's given typically in the pediatrician's office. But this is available to infants with pulmonary hypertension who are less than 12 months of age, or infants who have BPD or bronchopulmonary dysplasia, like prematurely born infants. They can actually get it up until the age of 23 months. So we do have this, it's not a vaccine, but it's a medicine, it's a monoclonal antibody that can be used as a treatment to help prevent getting RSV infection during the RSV season. It's not 100%. You can still get RSV even though you're getting these monthly monoclonal antibody infusions, but it has been helpful for many babies. Outside of that, there is Dr. Robbins was just telling me there is a vaccine that Pfizer is approaching the FDA about, and they're very hopeful that it will get approved. And this is a vaccine that is given to mothers in the late stages of pregnancy, with the thought being that getting an RSV vaccine to the mom will actually allow for the vaccine to cross the placenta and protect the baby. So the baby would be born with antibodies, and typically antibodies that are passed from mom to the baby usually last for about 6 months. So that would get that baby through the first 6 months, which is the most dangerous time for most infants to get RSV. But when it comes to pulmonary hypertension and respiratory infections in general in the pediatric population, we always worry about how a child with PH, how a child who doesn't have a lot of reserve will handle an infection. And that's where it's really important to talk to your medical team about treatments that you can have available. So a lot of the treatments that your family may suggest, or even your pediatrician may suggest, will be things that contain decongestants in them. And decongestants actually are not okay to use in pulmonary hypertension, because they'll cause your blood vessels to tighten up a little bit. So with any cold that your child gets, and the average child under the age of 5 or 6 is going to get about 6 to 8 colds a year. And that's not the PH population. That's the child without any medical issues. So that's pretty much one cold a month, every month through the fall and winter, right? So your kids are going to get sick, right? Because in addition to having PH, they're still kids and they're going to get sick. So the important thing is recognizing illness, getting in touch with your team, and making sure that whatever medications you are prescribed, that you're running them by your PH team. I'm going to break there and let Dr. Robbins talk about infections in adults. Please, any questions that you have, please write them into the chat. We do want to hear from you.
All right. Well, thank you, Nidhi. Didn't leave a lot for me to say. That's good. But no, there's a lot of these viruses are much more severe in children. However, as I think you're all aware, COVID was a deadly pandemic, and it's actually a variant of the coronavirus, which is what the common cold is, but it's a much more virulent strain of this that our immune systems had not seen before. And it's also like viruses in general, they mutate, so they change their shape. And so that's why I'm sure you've seen in the news many different variants. And the most recent one is the Omicron variant. And so we've had a whole litany of treatments for COVID, and they've changed because some of the treatments, for example, we're using 2 monoclonal antibodies as treatment. And just let me back up and say, because probably a lot of you don't know what monoclonal antibodies are, but these are when your body sees a viral infection or any infection, your body makes things called antibodies, which are basically little soldiers that go out there and attack either the bacteria or the virus or whatever inflammation or whatever infection it is. And so these pharmaceutical companies have made synthetic antibodies that attack the COVID virus. And so that was very helpful for a while. It was called Evusheld. Some of you may have had that or heard of people who've had it. It was really approved for people with compromised immune systems. But anyway, that now is not very effective because of the COVID variant that is out in the community has changed. So anyway, these viruses are very tricky to treat because they do change their outer coat, which is what these vaccines and treatments target. RSV, as you heard, is can be very deadly in small infants and babies. Not as much in adults, although it certainly can make you pretty sick. There is an oral therapy, ribavirin, that is helpful and is something we give our patients who are immunocompromised quite a bit. In terms of the flu shot, in terms of the flu, there are several medications for this. Well, there's a couple, I guess, but the most common one, and I'm sure many of you heard of this, is Tamiflu, which is your doctor can prescribe. It's a 5-day treatment, and you have to start it very soon after you get your symptoms. We can talk more about the treatments for these if you have questions about that. But sort of echoing what Dr. Varghese was saying, that in patients with pulmonary hypertension, your body's already stressed by the pulmonary hypertension. Your heart's under strain. And when you get an infection, it puts even more strain on things. And so these viruses can be very, really cause a lot of damage. And certainly some of our patients got very sick and even died with COVID because it put so much strain on them. There are 2 oral therapies out there now for COVID, Paxlovid and molnupiravir. And I would just be cautious about that if your primary care physician prescribes this, if you test positive for COVID, because the Paxlovid, while it may be possibly a little more effective, it interacts with several or numerous medications, including several pH medications, including sildenafil and Letairis and some of the other oral medications. It's okay, does not interact with the IV medications, but you need to be very careful about that. It also interacts with a number of medications that cardiologists use to treat people who have arrhythmia, so irregular heart rates. So again, you need to be very careful about that. And for patients who are immunosuppressed, particularly who've undergone transplant, the medicines that we use to suppress your immune system, in particular cyclosporin and Prograf, there's a huge interaction with that. So you have to be very careful about that. So I guess the bottom line I would say is to ask your treating pulmonary hypertension team whether these drugs are okay for you and safe to use. I think the final point I'll get at is a couple, well, 2 points. One, just to finish up with COVID, it is not only can you get very sick from it, but it also has been shown to sort of promote blood clots, particularly pulmonary emboli. So that can be another huge strain on your heart. And then the last thing I'm going to get at and really stress here is that if you take away anything from this webinar today, is that I think every treating physician in pulmonary hypertension community would recommend vaccines for these. I know there's a lot of issues out there about this. There's a lot of talk about potential side effects. And in my opinion, there's a lot of misinformation, but these vaccines can have really helped to control both COVID as well as the flu. And I would urge all of you, particularly if you have other comorbid illnesses, to get your vaccines. So I'll get off my soapbox now, but I think that's about, I'll stop there. I don't know, Nidhy, anything to add on that?
No, I appreciate that. Thank you so much, Dr. Robbins, for going over COVID and explaining just how viruses change over time. I think that's something that a lot of people don't realize that, for instance, the flu, why is there a new flu vaccine every year? You know, it's because that the flu illness, the virus itself, it changes, right? So it does shift its structure. And so we have to have an updated flu vaccine. And so, and I appreciate the point you made about vaccines, especially as a pediatrician. Vaccines are very important for us to protect our most vulnerable population, the infants and children, from just regular household diseases that once upon a time used to be fatal. But now we have vaccines that can really protect our kids from a number of illnesses, and some of which are respiratory. So there's a vaccine that you can get for children, which there's a similar counterpart in adults. And this is the pneumococcal vaccine. So this protects against various forms of Streptococcus pneumonia, which is a bacteria that can cause a lot of pneumonia and blood infections in children specifically. So this is part of the vaccine series that is recommended by the American Academy of Pediatrics and the American Council for Immunization Practice. And so that's Pneumovax in the older adults, and it's Prevnar in children and adolescents. So in addition to vaccines for flu, it's important to think about your routine vaccines as well. You know, Ivan, we have a couple of questions that have come up, so perhaps we should start addressing those. Are we just go in order?
Yes, or however you want to do it. This is Angela.
Okay, hi, Angela. All right, everybody, let's just go in order, and some of them we may be able to kind of put together. What are the biggest danger signs a PH patient should watch for with a respiratory illness, and when should you seek medical help? That is a wonderful question. Thank you so much. I think maybe perhaps we should have started with that. So the biggest danger signs is the first one, of course, is respiratory distress. So if you are having trouble breathing, if you're having trouble catching your breath, or if you're a caregiver or a family member and you see somebody is having respiratory distress or is not able to catch their breath, they can't speak in a full sentence to you, or they look like they're turning colors, like maybe they're getting very pale or they're turning somewhat bluish or dusky. Maybe they don't seem as with it, you know, as awake and alert as usual. Those types of symptoms right away, those are emergency symptoms. You need to get to a medical facility quickly. And that might mean even calling an ambulance, right? So we are concerned that your degree of respiratory distress is significant. But other symptoms, are going to be cold symptoms. So runny nose, cough, body aches, difficulty just kind of having energy to get anything done, nausea, vomiting. And while a lot of that is pretty kind of standard run-of-the-mill respiratory illness symptoms, some of them, like if you have nausea and you can't keep anything down because you're vomiting, one, you can get dehydrated, which is a big problem in pulmonary hypertension. And two, you may not be able to get your pH meds, right? So you might not be able to get your medication in because you're gagging on everything or you're vomiting everything. And that can be a problem. So if you can't take your pH medications, if you cannot keep anything down and you're getting dehydrated, you're not peeing, your skin feels dry, your lips look dry, your saliva is kind of thick and sticky, those kind of situations, you want to also get to medical facility and make sure that we can take care of you.
Yeah, I think that, and again, just the first symptom, maybe many cold symptoms, but even if you just feel more short of breath than usual, along with these symptoms, and that's something to be concerned about, which kind of leads into the next question. If you do have a pulse oximeter at home and your oxygen level goes low, or if you're on oxygen already and you need to use more oxygen, that would certainly be a need to get see your doctors and let them know about this, because it could be that you're just at the beginning of this, and we've certainly seen patients that sort of started off a little shortness of breath, and within a day they're on a face mask or even a ventilator. So you really need to just be aware of this. And I'm not saying rush to the hospital for anything, but just be aware of symptoms that are changing, because with pulmonary hypertension, your reserve is much less.
And Ivan, I'm going to see if you can take the next couple.
Yeah, sure.
There's a couple of questions here about Paxlovid.
Yeah, so Paxlovid, and I didn't mean to just besmirch the good name of sildenafil. There's also tadalafil should be avoided with it, and as well as macitentan, Opsumit, and then let's see, I had a little list here.
The question is, if you can't take Paxlovid because you're on sildenafil or tadalafil,
right.
what
Yeah,
can
I
you
know,
take?
but I just want to mention the ones that you should be concerned about, and also Bosentan's another one. So if you can't take that, there is another oral medication called molnupiravir. And again, it's just I think it's a 5-day course or a 4-day course of therapy. So you can take that, and that's what we prescribe for patients who have medicines that interact with this. Now, obviously, if you're sicker and you're admitted to the hospital, there are other medications such as remdesivir, which is an IV infusion given. I think you get it for 3 days, and then also some patients can get steroids. So there are clearly other options for treatment. But in terms of oral therapy, molnupiravir is another one that you can take safely with all pH medications. In terms of the incidence of viral infection, I don't think it occurs more in our patients. I just think that you, as we've mentioned, you have less reserve, and therefore, when you get an insult with an infection, your body just can't handle it as well.
Hi, Dr. Robbins. This is Angela. Can you spell that medication you just mentioned?
Molnupiravir, it's MULNUPIRAVIR. Yeah,
I'll put it into the chat.
yeah, it's a little bit of a tongue twister.
And if I put it into the chat, can everyone see that?
We can repost on the back end. If you want to just type it to us, we can post it. Make sure.
Okay, there you go.
And I would just make one more point about the therapies, is that these viral infections are completely different from bacterial infections. And so antibiotics that you get for bacterial infections, such as amoxicillin or doxycycline or levofloxacin, things like that, will not work with these viruses. They're completely different kinds of infections. So And our armamentarium for the viruses is more limited.
And I'm going to piggyback on that,
Yeah.
Dr. Robbins. And so one of the things that can happen with viruses, and this is not too infrequent, is that you're sick with a viral infection and then you get pneumonia. And so sometimes these are viral pneumonias. The viruses themselves can kind of take over a part of your lung and just kind of set up shop. I don't know if you guys have seen those Mucinex commercials where this guy kind of sets up shop in your lungs. And so that's how I kind of envision it. But when you get a viral infection, you can get virus particles in your lungs, right? And they can really create a viral pneumonia. But what we always worry about is bacterial pneumonia. And these are bacteria. We all have bacteria in our mouths. We may have bacteria that we have in the blood from another source, especially in children. This is very common. And so you can get bacterial pneumonias, which we treat them with antibiotics. And these are the kind of antibiotics that Dr. Robbins just mentioned. So Levaquin or levofloxacin is a very popular one that is used in adults. In children, amoxicillin is very common, or we may use something from the cephalosporin family like Omnicef or Ceftonir. These are different medications that we use routinely to treat to treat bacterial pneumonias. And then, of course, depending on how sick you are with the pneumonia, you may be admitted, you may be getting IV antibiotics, and sometimes it's a combination of antibiotics just to make sure that we really get at whatever is in that lung segment. So bacterial pneumonias are unfortunately, they're not uncommon, especially in the setting of a virus. So getting sick with a virus does kind of predispose you to complications like that. Somebody had asked here about pneumonia shots and whether the pneumonia shots are recommended. And from a pediatric perspective, the pneumonia shot is Prevnar, which is a pneumococcal vaccine, and that is recommended across the board because it is a very common bacteria, and it's the most common bacteria that causes problems for children. So that vaccine is given multiple times through infancy in the first couple of years, year and a half of life. So that is recommended for children, but that only protects against 7 types of this bacteria. So there are many more types of these bacteria. I think that's a confusing part of a lot of infections. Rhinovirus, for example, which is the common cold, there are more than 100 types of rhinovirus. So you can have rhinovirus many times in 1 year or many times in your life, and it's all just different types of rhinovirus. So sometimes it seems that you might be getting sick over and over again, but you may be getting sick with different things. So precautions that you can take, like vaccines, hand washing, recognizing symptoms early, these are all things that can help you get better quickly.
Staying with and this is Angela again, staying with the pneumonia questions, we thank you for answering for a pediatric perspective, but we do have a couple of more of, should they get the pneumonia vaccine? They're 54 years old with PAH, and how often should adults get the pneumonia vaccination?
Right. Well, yes, if you have another comorbid illness, I would recommend getting the pneumonia vaccine. I think if you don't, in general, I think it's over 60, it's recommended. There is actually a third pneumonia vaccine now. It's what we call the 20-valent, and I'm not sure what the trade name is for the generic, or the name of it is. But and we used to give both the Prevnar and the Pneumovax, but now this would take the place of those two. But that's something you can discuss with your primary care doctor or your PH team. But yes, if you have bad pulmonary hypertension, I would definitely recommend it, even if you're not over 60.
And is that annual, or is
No,
that?
sorry. No. So, well, then I don't know what the 20-valent, the newest one is, but the Prevnar, at least in adults, is only given once. The Pneumovax is given every 5 or 6 years.
Thank you. Let's see, going back.
So we're getting some questions on prevention.
Yes.
And so I think let's address that. So the number one thing that really helps with minimizing getting sick with a cold, because most colds are spread through hand to mucosa. So that means hand to your mouth or hand to your nose. So if your hands are not clean before you're eating, for example, or if you are in public and you're kind of itching your nose after you've touched a public surface, that's one of the more common ways that people get infected with the cold viral particles. And so hand washing is one of the biggest things that you can do to protect yourself. Masking, we've also seen a lot of benefit from masking, especially with COVID, since many of these viruses are transmitted through droplets. So masking minimizes how much you directly breathe in viral particles into your nose and into your mouth. Of course, then there is staying away from people who are sick, minimizing exposure, to illness either within your home or outside your home, and then taking precautions to protect yourself when you're in public spaces, and just hand washing, sanitizing, those kind of things. Ivan, there's a question here which I'm not entirely sure of what the question. I mean, of what the answer is, but the question is, how safe is it for patients to use portable oxygen concentrators in public places?
I was just looking at that. I believe they have filters in them. So
I believe so too.
And I'm going to need to double check on it, but I'm pretty certain of that because, I mean, we have it for, we use it for all kinds of immunosuppressed people. So I think it's safe, and I think it's safer than going around with your oxygen level very low. But I'm pretty sure they have filters in these machines, so I would certainly not leave your oxygen machine at home if your concentrators at home.
I agree, and I don't think that it's a need, that it means that you have to switch back to carrying an e-tank or a portable oxygen, like not a portable, but like like the big metal cylinder tanks. I don't think you need to do that. I also do think that the portable oxygen concentrators have a filter in them. To know for sure, you can always contact your DME and ask them for the model that you have. Is there a filter? You can ask them how often does the filter need to be changed or serviced.
Right.
So these are all good questions to ask your DME.
That's a very good question.
Yeah, I didn't know that one either.
I'll have to
Thank
do a
you.
little more research on that one, but I'm
Yes.
almost certain there's filters.
Thank you. Another question is kind of about the same vein of taking precaution. Do people need to avoid being in public places? Does the PH community, do we need to still kind of stay in lockdown, right? Do we need to be worried about congregating with people, going in shopping malls, et cetera? Ivan, do you have an impression on that or an answer on that?
I don't think there's a one answer fits all. I think in part you have to do what you feel comfortable with. I would certainly, particularly in the winter, avoid very crowded places, at least without a mask. On the other hand, and this is something we tell our lung transplant patients, is we want you to live your life. We don't want you to live in a bubble, and just be a hermit. So I think you have to weigh your risks and benefits. I think using a mask, as was another question alluded to, I would recommend that, particularly in the winter time and when people are much more indoors and in closer contact and large crowds. But I think you can go out. COVID is not rampant at the moment, but there certainly are these other viruses. But I think part of it's just how you feel about things. But I generally encourage patients to try and live their life as normally as they can. Just be cautious about things.
I agree. I say the same thing to our pediatric patients and their families here. The question that we typically get is it safe for my child to go to school, right? Should my child be in a school environment, which as adults, we all realize that schools can be a very big place of infection and just sharing of germs. And we have to weigh the risks and benefits of it, the benefits of socialization, the benefits of in-person continuous education versus the risk of infection. And so to echo Dr. Robbins, you need to talk to your medical team. So if your child or yourself, you may be at higher risk and therefore your benefit does not outweigh your risk. And so therefore you may need to be more in a lockdown type of a situation. But also you should talk to your medical team because this is going to vary from location to location, right? So there are times when certain parts of the country are really experiencing a surge in flu or COVID or RSV, and other parts of the country are not. So that the local outbreak, the local rate of infection will vary. And so your team will know the most up-to-date risk of what the community looks like. And so definitely speak to your local team to find out about that.
Hi, Dr. Robbins and Dr. Varghese, I want to bring up a question that came in through registration, and I'm seeing it again here. What about over-the-counter medications? If you have a cold, what can you go just to the store and get? And then can you explain if PH patients need to avoid decongestion?
Yes, they do. And we say, so one thing I tell all my patients that if it's a medicine you should avoid with just general hypertension, high blood pressure in your body, it's something you should avoid in your lungs. So anything with a D on it, Claritin D, that means it has a decongestion, and these are things like pseudoephedrine, and they can really cause your blood vessels to constrict further and narrow, and can worsen your pulmonary hypertension. So although very effective for drainage, they do have potentially very bad effects on your pulmonary hypertension. So we urge our patients to avoid them.
I agree, we do that. And one of the questions here is that if the medication is prescribed by the primary care physician versus the PH specialist, can the pharmacist tell you if it's safe? And they should be able to, but I think that these are things that are best managed by your PH specialist in terms of determining about interactions and whether there is a risk for you to take a certain medication versus not. So if you are prescribed a medication by somebody outside of your pulmonary hypertension center, please let your PH team know that you were prescribed this and you'd like to know if it's safe for you to take. One, because it's great to just touch base with your team and let them know that you're sick, because they may have some follow-up questions for you, like what is your oxygen saturation? How are you feeling? And don't forget about this. And we're seeing a lot of this in the community. Please, did you get tested for that, et cetera? And so it's always important to maintain that communication. And then if you are prescribed something this way, they can really double check the interactions and let you know how it's if it's safe for you to take.
Thank you. Also, when looking at vaccinations, how often do you recommend receiving the updated COVID-19 vaccines? I'm not sure if you mentioned this already.
No. So now there's, if you've gotten the whole series, most people should have gotten 5. The 2 basic ones and 3 boosters. The last one was the bivalent COVID vaccine, which was supposed to be effective against the Omicron variant. At this time, so if you haven't had those, you should get those first. At this time, as far as I know, there are no additional vaccines being recommended. My suspicion is that this will turn out to be something like the flu, where you end up getting a vaccine yearly for what appears to be the most likely variant that will be in the community. I mean, that's just my opinion on it, but I think there are more COVID vaccines to come. So at this time, there are no new ones, but if you've had 4 of them and you want to get the last one, I believe you need to wait 2 months to get it.
So once you get the bivalent, which is the latest one that's out there, you don't need to repeat that in 4 months or 6 months. You don't need to boost your bivalent booster.
Right.
That is considered to be sufficient. I agree with Dr. Robbins. I think that we're going to see this become an annual vaccine, similar to like the H1N1 epidemic that we had a number of years ago, that is now kind of rolled into our flu vaccination. So I think this will become something like that as well. And people do ask questions about the vaccine, about how safe it is. And speaking from a pediatric perspective, our pediatric patients, they are eligible to get the COVID vaccine starting from 6 months of age and up. And we have not seen any significant side effects. Some children don't even get soreness. Some children don't even get a fever or any symptoms whatsoever. So it's been very, very well tolerated. And we have not had really had any concerns about myocarditis, heart inflammation, about blood clots, about really any symptoms that have been kind of reported very heavily in the media. Here at Texas Children's, we have not had that in our PH population. So we recommend it universally for our pediatric population.
that includes the bivalent. Is that also recommended for peds?
Correct. Yes.
Thank you.
So I see someone asked about why is RSV testing not standard of care in adults? If you do present with severe respiratory symptoms, at least at our institution, there is a respiratory viral panel that is sent that includes the RSV. It's in general, if you go to a rapid care center, they generally will just check for flu and COVID now. So it's a little more involved test, but there are fairly common tests that will give you a whole panel of viral infections. So that is possible to get without a lot of special testing.
With, most people, for most people, RSV is not an issue.
Right.
Right. So for most adults who get RSV, it's a cold. It may be maybe a couple of days of cough, congestion, and just not feeling well. Where we really see a lot of risk and illness is in the younger children, specifically under the age of 5, and then specifically under the age of 1. So that's when RSV, for reasons that are not entirely clear, why RSV will be significantly more dangerous in the younger population. Now, this past year was a little different because even this past year, RSV in the 2022 to 23 season, RSV was particularly problematic for everybody. These are for children as well as adults. People were getting RSV. And the thought is that, again, for older children and adults, that our immunity waned, our immunity decreased. And so now we were just exposed to things that we should have had a little bit of immunity for, even though RSV doesn't give like lifelong immunity, it should give you a little bit of something. And that's why it was a bigger problem this year is what the thought is. But anyway, that's why I think that's not typically screened for in adults because it's usually not an issue. So this year has kind of turned everything that we know about viruses kind of on its head.
One thing that I also saw on here was just going back to the medicines you should avoid. Does that include NyQuil and NyQuil day? And I'm assuming NyQuil nighttime.
You have to look carefully at the ingredients on all these cold medications because I'm pretty certain NyQuil and Walmart's variant of it and CVS's variant have pseudoephedrine or some kind of decongestant. So in general, I would not take them. Now they do, I believe there are forms of it though that don't have the decongestant. So that is acceptable. But you just need to look out if the decongestant, pseudoephedrine or phenylephrine. These are medicines that, as I mentioned, can narrow the blood vessels further, cause problems.
Is there any relief if you are congested? Anything to take?
What we recommend is actually sinus rinses. If you're congested, you can do nasal steroids like Flonase, Nasonex, things like that, over-the-counter medications, over-the-counter or nasal steroids. Those can sometimes help, but they do take a little bit of time to work. Afrin, which does not have a D in it, this is oxymetazoline, right? I think I said that right. Afrin, as it's known. Afrin, it does not have a D in it, but actually the way Afrin works is by shrinking up blood vessels in the nose. So Afrin is not recommended routinely either, especially not as on the outpatient setting. So typically for nasal congestion, it's going to be medications. It's going to be non-medication things like sinus rinses. People sometimes like to do like nebulized or inhaled Vicks, like if you put Vicks in like a pot of water or something, just kind of breathe in the vapors. Things like that can sometimes help just decrease your congestion a little bit. The use of over-the-counter medications is tricky. And I want to respond to a question that someone has written in about pharmacists versus, I shouldn't say it as a versus, but instead of individual physicians making determinations about medication interactions. And thank you for that correction, that point of clarification. When I was referring to, it's important to speak to your team and let your team know that this is what I was prescribed by somebody. it's understanding that your pH care is given to you by a team. So your pulmonary hypertension specialist will speak to a pharmacy specialist or PharmD who is versed in pH drugs, right? Whereas the retail pharmacist or the pharmacist of your primary care physician's location may not be as completely familiar with all the pH medications or as up to date on the literature for pH medications. So you really should speak to your pH team about medications, and it's not to get the okay from your doctor specifically, but as an entire team.
Thank you. Going back, and I'm not sure if I need clarity on this question. It is that top question that Dr. Robbins was about to discuss. If your medications give you cold symptoms already, how do you know if you've caught the virus or just a cold?
So I'm trying to think, I guess by cold symptoms, I mean, some medicines will give you diarrhea and nausea. Some of the inhaled medicines can give you a cough, but I don't think, so they're a little different. I think we're talking about things like a fever and body aches, which I don't generally consider these medicines to give you. So, I mean, it can be a little tough, but I think if you have a fever, body aches, if your systems get worse, if you can't keep anything down, as Dr. Varghese said earlier, then those are things that may suggest that you have a viral infection rather than just side effects from your medicines. Or if anything gets worse, if you've been on a stable medicine for a while, that might also be another clue.
I think you know your body, right? So sildenafil can cause some nasal congestion, tadalafil as well, and that's not unusual, but typically you notice it more when you're starting the medication for the first time, and then it becomes either a baseline level of congestion that you get used to and you know this is my body, this is how it feels, or it completely resolves. So if you have other symptoms and you just don't feel right and you can't quite put your finger on it, you may want to inquire about getting tested for perhaps you do have a viral infection. It might look and feel a little bit different to you and may not be able to put your finger on it directly. But if you don't feel completely right, then you should contact your team. You should let them know. And you don't have to kind of wait for all of the respiratory symptoms or wait for, to get really sick with fever or anything. If you're just not feeling exactly right and you're worried that you might get sick, or maybe somebody around you was sick and now you're starting with symptoms, it's not a bad thing to get in touch with your team and just let them know that you're feeling this way and whether you should get tested for flu, for example. And I bring the flu up specifically because there are medications like Tamiflu, which if you're going to take them, they need to be taken within 48 hours of developing symptoms. And so sometimes people are like, well, I feel like I might have the flu or I may not. Let me just see what happens. And by the time we're contacted, we're already out of that Tamiflu window. So if you are exposed to the flu and you have even mild symptoms and you just don't feel like you're exactly you, reach out to your team and get a flu and see if you can get a flu swab and find out about whether Tamiflu is an option for you. And then, of course, as you're paying attention to your body, monitoring your oxygen levels, monitoring your work of breathing, people had questions about what's a normal SAT, like what is a normal oxygen saturation or how low can oxygen level goes. And again, that varies from person to person. So if you have connections between your heart and your lungs, you may have oxygen saturation targets that are very different from somebody who does not. So that's a question, regardless of whether you're sick or not, that's a question that you should always ask your medical team. Like, hey doc, I've got a pulse oximeter at home and I check my O2 sat from time to time. Like, when should I be worried, right? What's an O2 sat that's worrisome for you and that I should call you about? So I think that's an important question to ask your doctor so that if you are getting sick at home and you notice that your oxygen level is outside of the range that they want for you, you know that it's a good time to get in touch with them.
Thank you. We had a question about masks, going back to that conversation. Is there a recommended N95, KN95, or cloth mask that you would suggest PH patients utilize? Any thoughts on masks?
Sorry, I was trying to find that question.
Right.
Yeah, so cloth masks are not recommended. So, I put it this way, if you have nothing available to you other than a cloth mask, well, that's going to be better than nothing. If you have And a KN95, that's going to be better than a cough. And if you have a proper N95, that's going to be better than a KN95, right? So it's kind of like a spectrum of what is available and what's good to use. But the mask itself has to fit you properly. So I'm sure Dr. Robbins has to go through this as well. But for me, I have to get tested every single year. So if you gain a little bit of weight, your mask size may change. If you wear a beard during some part of the year and the other part of the year you don't have a beard, your mask size may change. So there's lots of different things that affect how well that mask can really protect you. And so when you look at KN95s or N95s or cloth masks, they're not all made the same. And so you want to make sure that you find one that really covers your nose properly, has a snug against your cheeks, and covers your mouth, and does not have any portal of entry, and can really kind of adhere to your face. And so you want to make sure that you're getting the right size. So then, because otherwise it's not really going to be helping you as much.
Yeah, the only thing I'd add to that is I see some patients wearing kind of the plastic shield over their face. And as comfortable as that may appear, I don't think it does a whole lot because, viruses and other infections, they're microscopic, so they just go right around that. It maybe gives you a little bit of a shield, but it's clearly does not take the place of a mask. So.
Thank you. This goes back to that conversation about concentrators, and I'm not sure if this is something you can answer right now. If you were using a concentrator on a flight where people are no longer required to mask, is there a higher risk of contracting a respiratory virus into your lungs due to the concentrator use? I'm not sure.
No, I don't think so. I think there's a higher risk of getting an infection because people aren't masking up anymore on planes, and so I would encourage you to mask up for your own benefit. But again, I think they have filters in them and should filter out.
I agree. I think that your risk of catching a cold on the plane is no different than the person sitting next to you. And so just masking up and protecting yourself as much as possible is important. Even if you've got nasal cannula in your nose, remember, you're still breathing around that. So you're still breathing in some of that ambient air, the air that's in the airplane. So masking up is an important part of that, especially because a lot of people around you are not masking. And when it comes to travel, somebody had asked a question about how do you know what COVID rates are like, et cetera. You can look on the CDC website. They give recommendations about different countries in terms of infections, whether there are vaccines that you need to get or infections you need to be aware of. I'm not sure if they have that for COVID. I don't personally know that, but you can look on the CDC websites and they do have that information for other infections and other illnesses. So it's something that's good to know when you travel. That again, this kind of goes back to what I said earlier and what Dr. Robbins had mentioned, that infection rates are different in different communities in different parts of the world. So be aware of where you're going and know what your risks are, and make sure you take protection with you to protect yourself while you're traveling.
Thank you. We are coming up on the end of our hour, so I would like just any final thoughts, any final messages you want to make sure that those watching have as they go through RSV, COVID, flu, whatever the case may be for pediatrics and for adults. So I'll let you have those final thoughts.
Go ahead, Adam.
Well, I think just to reiterate what we've said, get what vaccines you can. Be careful about being in crowds. I would recommend masks, particularly if your pulmonary hypertension or pulmonary vascular disease is severe. And, be in touch with your care team if you do get sick, and make sure that what you're being prescribed or thinking about taking is not going to, have any adverse effects related to your disease. So I think it's
I agree. Just communicate with your team. And by your team, that's the physicians, the nurses, the pharmacists, social workers, dietitians, et cetera, whoever all are on your team. Our job is to help you feel good, right? And live your best life through your winter, through your fall seasons, whatever viral illness season you're in. And so talk to your team and just maintain a communication with them to know what's normal for you, what's not normal, what they expect, what they don't expect, what medications are safe to take, what are not safe to take, and really kind of get some of those questions answered even before you're sick, and so that you know what to do in case you're ill. Figure out your oxygen sat target so that you know how to monitor yourself at home. And then you also talk to your team about, we talked a lot about travel and about your oxygen concentrator, for example, and about measures that you can take to prevent illness. But talk to your team about, is it safe for you to be in public places? Is it safe for you to fly? Is it safe for you to travel even by car? So these are questions that really your medical team needs to give you special, like personal, specialized recommendations for. I will tell you that I don't have one rule fits all for all of my patients, right? I have an individualized travel plan for each of my patients, depending on where they're going, how sick they are, what medications they're on. And so we want to be able to be part of that process for you so that you can get wherever you're going safely. And when it comes to viruses, we want to make sure that we get you through this viral illness safely.
Thank you. Thank you so much. Again, thank you to Dr. Ivan Robbins of Vanderbilt University and Dr. Nidhy Varghese of Texas Children and Baylor College. We appreciate your expertise today. And I just would like to share that we have recorded this and it will be posted to PH Association's website. You can also look for additional information on about PH on our website as well. Again, we will have a survey that pops up once the webinar ends. We appreciate you taking the time out of your day to join us, and we hope you learned a lot. Thank you. Thanks, everyone.
Thank you. Be well.
Have a good rest of the day.
Yes.
Bye-bye.
Bye.